Welcome to Science with Sanjula, where we talk about anything global health. My name is Sanjula Singh, and I am a researcher at the University of Oxford. Join me as I speak to world-leading scientists who tackle today's biggest challenges in healthcare. So, welcome. Patricia, would you please be so kind as to introduce yourself?
Thank you very much. Thank you very much for the opportunity. I'm Patricia Kingori, and I'm a sociologist. I'm based at the Wellcome Centre for Ethics and Humanity and the Ethos Centre at the University of Oxford. So I was born in Kenya. Mm-hmm. My dad's Kenyan. And then when I was about almost 3 years old, I moved to St. Kitts in the Caribbean, which is where my mum's from. And I then came to London when I was around 10, 11 years old.
When did you first become interested in sociology?
I first became interested in sociology. I became interested in sociology when I was around 13. And I found out that my local college had a course at night school. And I went along and I spoke to them and they said, you can start, but you have to have somebody, a responsible adult, signed to say that you can do it. So I went to my teacher and asked them if I could study, and they said no. They said, you've got enough with your schoolwork. And I came back home and I got really upset.
That's discouraging.
Yeah. I got really upset. I spoke to my mum and I said, look, I really want to do this course, but I need a responsible adult to sign for me. And the school have said no, so I won't be able to do it. And she just said, this is a really important lesson for you because, I'm your mother, I am a single parent, I'm doing everything for you, and yet you don't see me as a responsible adult. And this is a really important lesson for you in power and giving power away because you've went to the school and asked them. Those are the people who you saw as powerful, but in fact, I'm the most powerful person in your life. And that if you do this course, then you should use it to understand power in society. From that was it. I kind of thought, well, actually, there's a whole world out there that I'm really interested in learning about. I did sociology as a degree, which I really enjoyed and had fantastic tutors. And then it's really interesting because it makes it sound really smooth. I didn't even know you can really have a career as a sociologist. I'd never met an academic really before I went to university. But my mum always said, find something that you love and you never have to work a day in your life. And so when I went to university and I started to see some of my lecturers and my tutors, and they were so inspiring. I think because they were so enthusiastic and interested, I think they then really helped me to really see this as a career and just encouraged me to do a master's. And so I did my master's in medical sociology to do afterwards. Then I started just doing some research as a research assistant. And that was a huge eye-opener, working on different projects, but just gave me a particular insight into living in the UK because firstly I'd never had any real experience of the northeast or the north of England. I really started to understand how biased so much of our thinking is in the UK to the south and why so many people in the north are so aggrieved with the way that resources are divided.
You are involved in research on misdirections in global health, in which you make a parallel to magicians and to magic. Could you maybe start about explaining about misdirection in general?
Well, I think it's the right thing for me to say is actually that this idea of misdirection has come about from a collaborative piece of work I've been doing with colleagues in the Institute of Tropical Medicine in Antwerp, with colleagues at the University of Amsterdam, colleagues in different parts of the country and different institutions in Europe and part of the world. But it's inspired by our work with the Institute of Magic at Goldsmith, and they've been looking a lot at how misdirection works, not only as a kind of a technique of magic, but the psychology of it and how it's used by politicians and how it's used in many areas of life to potentially to focus our attention on one thing, when in fact what we should be doing is looking at something else. So if you imagine when you're a magician performing a trick, a large part of that trick is misdirection because they get you to focus on the coin when in fact you're supposed to be focusing on the card, or you focus on one thing when you're focusing on another. And I think that our collective thinking was that actually this is something that would be really useful to think about how we've got to this particular point of intractable inequities in global health.
And then I wonder, because if we're talking about a magician, it's an intentional misdirection. Do you think it's intentional or it's not intentional in global health?
I think the intentional question is a really interesting one, and it's one that we've really thought a lot about, because with the magician you can say that they actively intend to misdirect you, but with health sometimes it's much more complicated. So there are definitely people who think that some of these misdirections are intentional and they're strategic, and there are other people who think that we've been misdirected by accident, but in fact nobody wants to really acknowledge that that's going on. Often the way that things are evaluated in global health, a program is evaluated, is that they might count the number of items that are being donated or given or taken, right? So we might say this has been a successful vaccination campaign because 2,000 children have been vaccinated against polio. So that's what they tend not to do, is to look at, for example, what was the quality of those vaccinations that were given. But what we're constantly told to do is just to count things.
Yeah.
If you count things and they can be counted, then that's great. And we're often misdirected to just to counting things and to quantifying things and looking at the statistics, whereas in fact there's all these other things that we probably are more important and we ought to be looking at. I could purchase from you, from Holland, really high quality vaccinations and they can travel to Kenya and they sit in Mombasa in a shipping container because the paperwork hasn't been sorted out. They sit sweating in the shipping container, but eventually 2 weeks later they're fine, and then they're transported in a truck to a remote part of the country. By the time they arrive, the active product ingredients of that vaccine, because the cold chain has been disrupted, diminished.
Yeah.
But there's no way for us to capture that. And so there's a question around who are these vaccines designed for? When we're talking about misdirection in global health, it's actually just a conceptual way of thinking about what are we giving attention to that maybe we should not be giving attention to, and what else are we not looking at?
And what can we do at this stage? For example, young researchers, how can they contribute to maybe looking the other way or even discussing that with people?
I think this is where having diverse voices in a room really helps, because I think if I'm talking to you from the context of somebody in the global north, what I'm saying to you is really surprising. That, medicines, a lot of medicines that go to people in the global south are transported without a cold chain. Paperwork isn't sorted out in advance. People get things that are expired. This is a shock to us. But if you're talking to somebody in the global south, it isn't. And so actually a lot of this idea of illuminating people and bringing attention to things is actually just having people in a room who are prepared to say, this cannot work in my context. When you talk about room temperature, you're talking about 25 degrees. Most parts of the world don't have a room temperature that's 25 degrees.
Yeah, right.
So even just these really small default things are things that if we had diverse voices in a room, it wouldn't be such a shock. It wouldn't be such a misdirection. A lot of our discussion around ethics and global health is about resource allocation. I'm arguing, and you draw the attention to the fact that actually there are ethics in the design of these vaccines, right? Who gets to decide what room temperature is? And when you do that, what are the ethical implications for the rest of the world? If I decide that room temperature is 35 degrees, because that's the room temperature for most of the day in Nanyuki, where I was born, that has huge implications for the rest of the world.
It's a big decision to make.
But this is the way that all of these vaccines and medicines, when you say they have to be kept at room temperature, this very simple decision has huge ramifications for whether the people have access to fridges, generators, electricity, all of these things. And so what I'm arguing for in the misdirection work is for us to really start rolling back where we start to have some of the ethical discussions.
What can we do to pave the way for pretty much the next researchers?
I think it's a good question. I think one of the things I think is really important for me, I'm not necessarily advocating this for everybody, it's just my own personal politics, is whenever people tell me, that I am the 1%, I think there's sort of two ways of sort of dealing with this. One way is to say sort of thank you and take it as a kind of, yeah, I'm great.
Yeah.
But actually, I think a lot of this is, I always say, you know, there's more out there than me. Like, this isn't,
right.
I'm not just here like as this kind of alien unicorn person, you know. If I'm here, then there are other people here. So, you know, give people a chance to come and tell you. If somebody had the resources to come to Oxford to talk to us, then fine, we'll listen. But how often do we put ourselves in a position to say, you know what, I wonder how this works on the ground, this stuff I'm designing. I think there's sort of pros and cons of being in a space where you're saying you're from the University of Oxford, because people expect you to be experts on everything. So I think it's really important to add to the space of humility. Even if you know what you think you know, you always have to allow people to be the experts, because they are of their own lived experience, right?
Right.
So there's nobody that's going to know more about what's it like to be dispensing medicines in a rural part of India than the people who have to do it. So I just don't really trust a situation where anybody pretends to be the expert across all things, you know.
There's another topic I'd like to discuss, which is about something you have called the genuine fake. Could you please explain to us what does that mean?
So my understanding of the term is that it initially came from demography, and it applied to data that was essentially fabricated, but with real results. So it's where there's a flaw in the method, but the results are the same.
And how can something like that come to place? Is there a certain rationale behind why that happens?
Yeah, so that was part of my work, is really trying to understand that. Firstly, why would somebody fabricate this data? That was where it really started from, because when somebody tells you they've fabricated a survey, you think, well, they're just lazy. I think that's the general feeling.
Yeah.
But so in producing genuine fake data, one of the things I found really fascinating was, one, it took more work, but two, it was actually an insight into a different type of expertise. So often field workers who fabricated data, be it demographic data or clinical trial data, this was knowledge that they had acquired about the participants over time, such that they didn't even need to go and visit them. They would know, well, Patricia doesn't have 3 meals a day because Patricia lives in a context where nobody has 3 meals a day. And so I found this really fascinating as a kind of different way of understanding science and science in the making, you know. And there was a fantastic study that was done in South Africa where they repeated the survey that were falsified by these field workers, and I think there was some sort of, this finding was like 70% of them were correct.
Wow.
So it was really fascinating that actually you could conduct a piece of work, and just through your own experience of doing that task over and over again, you can predict human behavior in this way.
Right.
So the idea of the genuine fake came from that. This is like this thing that exists in two states. It's fake because the method was wrong, but it's genuine because the results are real.
I think one example may be drugs.
Yeah.
Am I correct?
So it's possible to have a fake drug that is real and produced in a fantastic factory that meets all these international standards in, I don't know, Rotterdam or somewhere. And but its active product ingredient has depreciated or devalued to such an extent that the amount of that drug in the amount of the product in that medicine is lower than a drug that's been produced not by the same manufacturer, you know, in the middle of, you know, bad practices, but that drug actually has more active product ingredient and actually works better than the genuine drug. It's actually, to me, indicative of the kind of complexities of sort of real world situations where, because of the lack of attention to the infrastructure of medicines that we were talking about, because of that, it then produces these other types of problems, right, where you can have a drug that is authentic in its origin, but in its sort of practice and implementation, is fake because of how much it has involved. So, talking to colleagues, frontline physicians in Liberia, Sierra Leone during the Ebola outbreak, and them talking about receiving medicines and these were medicines that were necessary and really needed, but because of the way that they were transported or because of the lack of any of the proper paperwork, they just couldn't use those medicines. And so those medicines had to be destroyed. And that has all sorts of implications, right? It's the opportunity cost of being able to potentially save lives. It's the dilemma of the physician of whether to give medicines or not. The 21st century has been described as this kind of crisis of the century of the crisis of authenticity, where we don't know what's real or fake. And I think this is really interesting because if you speak to historians, they'll say, well, no, actually, there have been other crises of authenticity. We are at a time when it's really, really difficult for us to often get certainty about whether something is real or fake, especially if it's something that's online. So technology definitely is playing a really important role in really challenging us to really try and work out what is real and what is fake. And because of that, we are really thinking now about all sorts of other areas of our lives, like how do you know I am who I say I am? I think that really the thing that fascinates me is what this means for all of us in terms of what it demands for all of us.
All right. It's a trust issue eventually, I think. It's also a decision to trust an institution or to trust that the website is real.
I think you're right, but then the onus and it puts more responsibility on institutions to be custodians of trust, take that trust really seriously, so that when somebody say that they're a doctor and the GP, that people trust the General Medical Council, that they would not let somebody practice if they weren't qualified and if they didn't pass all their exams. So I don't know you and you don't know me, and you could be my GP, you could be my doctor, and the only reason why I'm trusting you as my doctor is because I know that there's structures in place to ensure that you are who you say you are. So I have to trust those structures.
Could you please share your life advice for all the people listening to this podcast?
Professionally, I think this is a really difficult time to be a young professional, because we're coming out of something that the world has never experienced before, and nothing prepared them for this, or us for this. But I think this is a chance to sort of remake the world in a way, and to do things in a way that works for them. So I think one of the things that's been really fascinating about COVID is that it's made a lot of the things that people said were impossible possible. And lots of people have left feeling really vindicated about their productivity from working from home, redesigning the types of jobs they do and how they work. And I think that it's really important that we don't lose that, and that we don't default back to a position where people are really disadvantaged by working to a style and to a way that only suits a very small percentage of people. And I think that younger people starting their careers, if this is all that they've known, then this is what they should hang on to and fight for, I think. And personally, I think we've been through a time with Me Too, Black Lives Matter, the Great Resignation, huge seismic social shifts that hopefully have brought us to a point where people feel more confident in speaking up, and feel more confident in really questioning lots of the acts of power on them. And I would really urge people to hang on to that and keep questioning whether when people act in a powerful way towards them, whether they have the authority to do that.
Patricia, thank you so much for talking to me today. I had such a good time having you in the studio. And thank you for all of our listeners as well. For next episode, we'll be having Sir Tim Hitchens in the studio, and we'll be talking about diplomacy and healthcare. Please tune in.